Good afternoon, everyone. Welcome to our panel on youth behavioral health, natural disasters, building capacity, partnerships, and resilience. Um, just to introduce myself, my name is Melanie Ailey. I'm program manager here at Vibrant in our equity and belonging division. My job here is training and outreach, and I have the distinct honor of introducing our panelists for this afternoon. Um, so we'd like to first introduce Dr. Melinda Baldwin. She is the director of the Division of Prevention, Traumatic Stress, and Special Programs in the Center for Mental Health Services at SAMHSA. Dr. Baldwin is a subject matter expert in behavioral health trauma, program evaluation, and its intersectionalities with child welfare and maltreatment, and mental health practice and policy. She Before coming to SAMHSA, she worked at the Child's Bureau, leading their work in behavioral health and trauma. She also has extensive field experience not only as a social worker with families in the social welfare system. She was also the director of child welfare at Hepzibah Children's Association and holds a doctorate, a PhD in social work from the University of Illinois at Chicago, an MSW at the University of Illinois at Urbana-Champaign, and is a licensed clinical social worker in Illinois. Welcome, Dr. Baldwin. Our second presenter is Mr. Matt Reddam. Mr. Reddam is a licensed therapist and current school and community wellness advisor for the Butte County Office of Education and is the former policy and practice coordinator for Trauma Transformed in the Bay Area. Matt is recognized as a regional expert in traumatic stress, and is an advocate for all marginalized and historically subjugated populations, which I thank you for your work, Matt. And also, he began his career as a therapist and has quickly found that systems and communities often pathologize our children's attempts to survive. Um, and this led him to shift his work from individual treatment to consultation and training for large systems. He's also a survivor, a student of racial justice, and a father, and he continues to do this work, the line of learner, expert, and fierce advocate. And we also would like to discuss lives in Chico now with his wife Megan and their two children Liam and Caleb, his living examples of resilience and hope. Thank you, Matt, for being here. And also our next presenter is Mr. Robert Stiles. He is the program director of the Department of Behavior Pediatrics, Telehealth, the ROCKS program. He has a strong background in access to care for underserved populations and has extensive experience in pediatric behavioral health and access to care, including serving as director of the Kansas Primary Care Office. He's also worked at a local level in executive positions with federally qualified health centers, developing and managing primary care and community and school-based health in the states of Kansas and Missouri. In his work in University of Kansas Medical Center, he was the program director in the Department of Behavior Pediatrics Telehealth ROCKS program, which focuses on behavioral health and social determinants of health in order to foster an environment where every child has the exact same opportunity for success in school and in life. We thank you so much for your collective brilliance, and we look forward to hearing what you're going to give to us today.
Thank you so much, Melanie, and we're so honored to be here. And I do want to acknowledge one of our colleagues, Evelina Tarrin, who was supposed to be with us this afternoon, but due to an appointment that just could not be moved, she couldn't be with us. So she's a very active leader in this space and did an amazing job pulling a lot of this together. So we miss her and honor her at the same time. I'm just going to kind of paint the picture of how this program came about in SAMHSA, because it's a very unusual program for us. And then I want to turn the floor over, so we spend most of the time hearing from the really good and thoughtful work that Robert and Matt have done. So when Robert pulls up the slides, you'll see our Assistant Secretary, Dr. Miriam Delphin-Rittman. She is our Assistant Secretary for SAMHSA, and she has worked since her administration to set 5 priorities for us here. Preventing overdose, enhancing access to suicide prevention and crisis care, promoting children and youth behavioral health, integrating primary and behavioral health, and using performance measures, data, and evaluation to move our work. We're just on slide 2, Robert. And then across those 5 priorities, and you can see each one of those touches what we'll talk about today. She's identified equity, workforce, financing, and recovery as especially important for us. And those cross all of the work we do. And then if you go to the next slide, Robert, you'll see SAMHSA has a significant investment in communities, especially targeted to children, youth, and families. It's to the tune of $1.5 billion, and that is a B. But I do need to caveat that in that we have included but a percentage of the substance abuse block grant and the mental health block grant. But you can see the programs of regional and national significance there. These are our discretionary grants that we issue on a regular basis. And so those, if you'd like to learn more about those are on our website. But today we're going to talk about a very specific grant program, what we call the disaster response grant program. And this is a unique program. We had never done it this way before. We hope that we are able to do it again, but it's not something we do on a regular basis. And we were appropriated $100 million to provide behavioral health treatment, crisis counseling, and other related supports to adults and or school-aged children, adults, and then children in school-based settings. And the reason that's kind of wordy is because of the way these grants were structured. So the school-based grants were issued first along with the adult services grants. And you can see we gave out 16 school-based, 13 adult services. And then later we issued grants to states, and those were a little bit shorter, and there were 13 of those. So if you go to the next slide. And this is also really important, is that the legislation specified that eligible applicants were from any state, territory, domestic, public, private, nonprofit entities, but they had to be in communities that were in the paths of Hurricanes Florence and Michael, Typhoon Mangkhut, and Super Typhoon Butte, and then wildfires and others that had been in communities that have been declared federal disaster areas. So this is really important, that only communities that had been involved in these natural disasters could apply. So the interesting thing is that this program, grantees applied for this work before we went on lockdown. So their grant applications were due before March of 2020. And we did not award them till afterwards. So if you can imagine, folks came to the table saying, we'd like to do X. And then all of a sudden we were like, oh, can you still do what you said you were going to do? But we're in the midst of a pandemic. And folks in communities that had suffered the disasters that we just talked about were also in the throes of experiencing COVID and all of the things that were happening at that time. So when we brought these grants together, there were 3 of us here at SAMHSA that were tasked with leading this work. And it soon became really apparent that because of the way the grant was structured, we had grants in communities, but they were like on top of each other, meaning that we had to figure out a way to bring folks together because they appeared to be serving the same people. So what you can see with the different color bands on this slide is where in communities, how many grants were in one community. So we had to begin to start to figure out, how are we going to do this? So at SAMHSA, we decided to do something that has not been done, and it has not been done since, is we were going to work together as a team, and we were going to bring these grantees together in ways that we had never done before. So the next slide shows you how we started parsing this out. And this is just an example of Florida. This is a county map, and the color density indicates how many grant programs were serving particular counties. And so we had to figure out a way to bring grantees together so they could work as a peer group in working in relatively small areas with an awful lot of different grant programs and different outcomes and goals. So it was a very interesting way to approach a grant project. So next slide. So collaboration coordination was very, very important in a very different way than we're used to doing at the federal government. We had to have very intentional and leveraged relationships. So we were leveraging relationships in lots of different places because these grants were financially also structured differently. So we had to get our grants management folks on staff, and I call all of these folks that came together the SAMHSA Dream Team, because they worked together like a team I've never seen before. And so we were working at multiple systems. We were working at individual grantee level systems, helping folks get situated. We were working across grantees, and then also helping them work at the family and individual level. And then we had to sort out the whole data collection system, because each of these grants were collecting different data elements, and they were putting them in different systems at SAMHSA. Next slide, please. So here gives you a sense of what data we have been collecting. So as you can see, some of it is in common, but others are different. So the whole adult piece was very different. They're in a different system. They're in our substance abuse treatment system, which we don't use as much at CMHS, but school-based and state grants were doing much more of the same. And as you can see, a lot of the state grants were working in the child space as well. So just kind of overall across, next slide, please, Robert. When we look at successes and challenges in terms of, these are themes that we saw across all the grant programs, is that the successes is in COVID, when people were at home and may not have been going to school or may not be going into the office, it was a fabulous opportunity to reach folks for training. Our grantees stepped up and retooled their intervention for this new environment. They had school districts that were flexible, but there was a lot of clinician burnout. So they were able to really think about that and figure out unique ways to address that. Some of them worked with tribal nations, and telehealth, of course, was new in many communities. And so this was both a success and a challenge. Some of the challenges were just figuring out, how to change your service delivery system, because of what you said you would do pre-COVID looked very different post-COVID. All of this overlap in personnel between the grants. How do you reach parents? If kids aren't coming to school, how can you reach parents for screening, consent interviews? Referral pathways were disrupted. How do you use telehealth with families with children doing virtual school when there might not be private spaces? And, we often don't think about, we think of a large grant as being a gift, but it can also be very difficult. It was an awful lot of money for each grantee to spend in a pretty short time frame. And so they had to be very deliberate about how they were going to use their money. Some of the considerations across that we saw grantees thinking about and building up their expertise in is how to build resistance. What does that look like in the face of crises that keep piling up? So we had natural disasters, we had pandemic hardships, we had poverty. Many folks had lost their home in the fires, and they're just now getting back into their homes. There was lots of unemployment, and there was a lack of social supports. And these were happening at the individual level, at the family level, and at the community level. we were when we began, there was lots of grief and loss, and we hadn't begun to think about what we were seeing in the ways that I think that we're thinking about it now. And Matt and Robert will share more about that. And we were stuck in this place where we had to insist in a way that we followed the funding opportunity announcement, but we also had to figure out where there was a give because of the circumstance had totally changed. So this context, we talk about it, and it's been an example here at SAMHSA because it was a situation that we had never seen before. Next slide, please. So just to give you a sense, and I'm going to focus on the school-based services data, both in this slide and the next slide, is looking at what we saw, and this is over fiscal years 20 and 21. So, and this is over 16 of the school-based grants. So as you can see, we did an awful lot of training. So with 16 school-based projects, over 9,000 people were trained. Over 16,000, almost 17,000 individuals were screened for mental health or related interventions. And then of those, 962 were referred for more intense treatment. And you might say, well, whoa, that's not very many referrals out of that many screenings. Just so you know that several of our sites implemented universal screenings. So there were several sites that were screening every child who was in care or in school. And what was a result of that is, although perhaps a particular child wasn't eligible or didn't need individual treatment services, their parents became much more aware of some of the things they needed to be mindful of. And so in one grant site, the parents asked to have their own training program. And so the grant was able to actually put a parent training program into place. And then the last data slide I'd like to share with you before I turn it over to my colleagues is what our outcomes are looking like. So this is individual data that grantees gather from individual consumers that are served. So out of all those folks that were served, 1,416 of them were served in such a way that they were receiving individual mental health services. So you can see that we saw some really nice increases. There was about a 67% increase in the way folks reported they were functioning in everyday life, that 59% of them felt more socially connected. And then some smaller numbers, just over 13% said they weren't experiencing psychological stress, 12% felt healthy overall, and 8 or almost 9% were attending school regularly or currently employed or retired. So really that's attending school regularly. And so you can see that, this data is what we collected, but it's not reflective of the larger grant program. So I want to turn it over to my colleague, Matt Redmond, to get more into detail in terms of specific programs.
Thank you, Melinda. I appreciate it. I just want to take a second and thank everybody who worked on this grant, especially my colleague, Scott Lindstrom, who's been, what we don't talk about or what's hard to talk about is, as coordinators in this particular grant, we were all impacted, right? Not all of us lived in Paradise, but all of us lived in Butte County, California, which has seen ongoing disaster and crises for really the last 4 years. So Scott has been a rock for me and is the lifeblood of this work that we do. Tom Taylor, the superintendent of Paradise Unified School District, and all of our fire recovery counselors, Karen, Elaine, Robert, Monica, Melissa, Tina, Debbie, they are the work. And they have, a lot of them have come out of retirement to do this work and have continued with us. And that's hard to quantify. It's hard to put a value on that. It's hard to put data on that. But as members of the community that was ravaged by the Camp Fire, which occurred in 2018, burned 153,000 acres. 18,000 structures, and it was the most deadly wildfire in California history with 85 fatalities. So part of our work was to continue work that this community was already doing and then add supplemental support. Fire recovery counseling, which is what we call it, placed counselors in every school initially in the county, but this grant in particular continued this work in Paradise, California, which was the epicenter of the fire, along with Magalia, Concow. Counselors were placed at each site for screening, referrals to more intensive services. But the really unique thing, and I think when we get into the questions, we'll talk about what it means to do mental health in a rural area. A lot of what they were there for was immediate crisis work with kids, immediate counseling work with kids. And a lot of them were known entities and quickly became embedded in the school system. They also worked with staff and administration. We provided staff support, which was not our original plan, but we partnered with the Trauma Resource Institute, Laura Vandernoot-Lipsky, provided monthly support around secondary trauma and overwhelm. We had a grief and loss training this last year with Dr. David Schoenfeld from the School Crisis Recovery and Renewal team. Substance abuse services, we partnered and subcontracted with a local CBO that funded several positions. That funneled down into one position, and that individual used the brief, which was a evidence-based way of working. It's motivational interviewing, cognitive behavioral therapy. It's a blended model, and it's 3 sessions, and it's designed to begin the process of addressing substance abuse with teens especially, which is a tremendous gap in rural areas and really in the state of California. We also subcontracted with Mindful Littles, who did social emotional learning curriculum. They went into classes virtually during the first year of the grant and discussed self-regulation, did mindfulness lessons with kids, and increased SEL skills. And then we did some case management as well. There was a lot of case management going on right after the fire, but oftentimes we would refer families to needed services, as well as if there were a need for more intensive services, behavioral health services.
Looks like it's my turn. So what's really interesting is in Kansas, and our program is really based on, and I know that Matt would say the same thing, that it's my boss, who's a clinical psychologist, just asked me yesterday, at what point does recurrent disasters just become ongoing trauma? And that's really what, whether it's, yes, that was based on that fire, which was, a substantial fire, but we all know that those communities that are impacted by fire will continue to be impacted by fire, will continue to be impacted by other natural disasters. So Kansas is like that, right? We have floods, we have tornadoes, we have winter storms, we have, I lived in one of the communities that we serve through this grant, Coffeyville. And there was one week when I lived there where we had 5 tornadoes in 1 week, one of which was the Joplin tornado, which passed over us and went 70 miles away and almost totally destroyed that town. I was with the Kansas Department of Health and Environment when Greensburg happened, so these are communities. Yes, this funding was based on a disaster or a year of disasters, 2019, which was a substantial year for disasters in the US. But these are communities, and also the funding happened in April of 2020, quite substantially after the disaster. And yes, recovery still needed to happen. But I think all of us are trying to prepare our communities or create, resilient communities and resilient children that respond, are ready for the next disaster because it will happen. So we did a tiered model. So when Melinda talks about, the number of students screened versus the number of students receiving services, you can kind of see we did a lot of universal interventions. We focused on skills for psychological first aid, and then targeted skills for psychological recovery, and then intensive trauma-focused CBT and other interventions. So Kansas, 50 out of 105 counties qualified. We ended up working with 11 school districts in South Central and Southeast Kansas. As I said, or was introduced, our goal was really resilient children and resilient communities, 19 sites in 10 counties, and direct services to 650 students during our year of funding, and echoes and other telementoring and training approaches to more than 1,000 individuals. So this is a slide that I Evelina stole from somewhere else or something I'd done at some point, but I think it really kind of feeds into something that Matt and I have both, where did we go? And we'll get to that when we get to the questions. But I think, and I guess the way I say it, and I've been saying it a lot recently, when we look at COVID, when we look at natural disasters, yes, all children, everyone in the community needs support as they recover from that disaster. But what I came to understand was whether it's COVID or anything else, those children that have resources that don't have daily traumas of life are not living in an environment where their resources aren't met. These the social determinants of health, those are the children that have the most issues, that are going to they're not going to respond well. And we can work on response to the incident, but we have to really move into working on this situation. What is it about the environment that creates a situation where children aren't able to deal with incidents that happen, such as a natural disaster, such as COVID? They're not able to recover. And it really gets into social determinants. And we both continued work. We are fortunate to receive HRSA funding to specifically focus on social determinants of health through what's called the evidence-based telehealth network program. And we're using community health workers in schools, and I'm really excited about that work. But, we've got to really look at this 80%. And, in your life, 80% is your social determinants. It's the same thing with recovery or dealing with a disaster. 80% of that is going to be the resources you already have in your life that allow you to recover or deal with that. So really important to look at local resources, social supports, care coordination. I just wanted to bring that up, and I know Matt will talk more about it. We both believe strongly about it. So we have about half an hour left. We developed 4 questions that we're going to kind of look at and kind of answer. So I'll start and ask the first question, and Matt, you can go first. So it is about, from our respective areas, what gaps exist in disaster response behavioral health? Are there any gaps that you've been able to mitigate, any that you're not able to mitigate, and why? So Matt, go for it. We both love to talk, so I'll try to cut it off.
Matt, go for it. My boss fears those words every time. All right. Look, when you think about disaster, which I didn't, I thought about traumatic stress a lot. I never thought about community trauma. I thought I knew all kinds of stuff about trauma, and I did. But what I've learned is you have to think about the community as an organism, right? And it functions like an organism, and it responds to traumatic stress in the same way a human body does. But when we look at different communities, there is a distinct difference between rural, which is ourselves in Butte County, we're considered rural and semi-rural. Paradise is absolutely rural, versus urban versus suburban. Human capital is our biggest gap. We do not have enough clinicians to satisfy the need that we saw. We knew that, we've known that, right? That is not an issue that's suddenly going to change tomorrow. It's not necessarily even going to change with funding. So it really, this gap was there and we knew it, but it is exacerbated when you start to do the work, right? And if you think about it in a traditional way, which is we have symptomology, we have distress, we need then a clinician to navigate and treat that distress. I think what we have learned is you have to think more broadly than that, because that may not exist. And I think the other thing that the gap that we learned on the fly was the impact on staff. So it was a school-based grant. So we were working with every school in Paradise, in Concow, and in the charters up on the ridge, which is the area in Paradise, California. I don't think we realized, even now, almost 4 years out, the impact on our staff, our administration, our teachers, and that it was not acute, right? So there is no linear way that disaster recovery works and resilience works and healing works. And we know that, right? You can read that millions of places, but when you see it, that gap begins to feel like a chasm and not a gap. We've been able to mitigate that somewhat, right? Because we recognized it. But I will say, and this jumps sort of to the second question, is the only way we were able to mitigate it was the prior relationships we already had with that district, with those schools, the work that we had all done around trauma already, because the ACEs in California and especially Butte County were sky high adverse childhood experiences. So this grant enabled us to continue having adults who had done the work sitting in front of kids, not on a specified time whenever they needed it. We had substance abuse services, which is a tremendous gap in the state of California, especially for teenagers. And you also have to realize that this is a community that didn't necessarily trust systems. And so even if you had a robust mental health system, I can't guarantee you that a lot of those families would be like, yeah, sure, go ahead. Because there's an inherent distrust in rural environments at times of government systems and families in the community. I think we were able to bridge some of that gap. I think that trust and relationship enabled us to mitigate some of those gaps, as well as folks coming out of retirement and doing the work. We can't mitigate what Robert just talked about in the previous slide. The context that exists prior to disaster are only exacerbated by the disaster. There isn't some magical way that federal money or state money solves entrenched socio-cultural problems. And rural America is bludgeoned economically. And so that has an impact on behavioral health. That has an impact on the efficacy of evidence-based practices. That has an impact on trust of systems. I think each and every time families and communities see things like this work, it inches us closer together. But many of those families are still in a double wide trailer with 3 other families. There are kids who still don't have proper dental care. And so those sort of byproducts of life exist, and those are not things that can be mitigated just through a grant.
So what I would say about gaps, and it's something that Matt brought up, but to say it explicitly, I think you have to understand that those in the local area are there when the disaster happens, right? They're accessible. But also, if you're talking about a community and you're talking about how to respond to a disaster, the leaders in the community, the people that are known in the community, the people that are part of the community are the people you want to prepare so that they're able to immediately respond. You need to go with the people that are trusted, that are known, whether that's school, staff. But we spend a lot of our time, understanding that another disaster was going to happen, right? We had to deal with the traumas and the recovery from previous disasters, but we really saw our goal with this grant as to create resilience, right? To create a resilient community that could respond to a disaster. And it was really interesting, right? I mean, as Melinda said, we applied for it and we were hearing of COVID as we were applying, and then everything shut down. One thing you have to understand is that things you depend on, right? Places that you think will get to kids through schools. Well, we were doing this grant in a disaster and school wasn't in session. So how do we do that? Right? Which is a perfect question about a disaster. I mean, we kind of got a disaster response grant in the middle of a disaster. What Matt said about staff is crucial. We're still struggling. Right now, we're spending our entire next year on resilience for teachers. We feel like whether it's the healthcare profession, whether it's the school profession, we have seen so many leave, but we kind of made this decision this spring that unfortunately, many have left or were leaving. This was going to be their year, and then they were gone. And I think we did see a huge outflux. But we were going to commit ourselves to spend all of next year, and we did a big kickoff webinar and told our school districts statewide, we're here for you the whole year. And we tricked our teachers, we're tricking them by saying, we're going to teach you techniques you can use with your kids. But for you to learn how to do it with your kids, you have to do it with yourself, right? Because we found when we did resilience through this grant that teachers came, but it was one more thing and they saw it as work. But they're struggling with their kids. They're trying to understand their kids. And so we thought, well, if we kind of do it and we figure out a way so we're not adding to their work, but we're helping them better be able to do their work through teaching those techniques that'll work. And then the final thing I'd say, one of the things that we find in a disaster is, and we struggled with in our state, so much of emergency management, their approach to a disaster or what the people that go in, to kind of respond to disaster, they're outsiders. But the second thing is we come from a culture where the idea is you process the trauma, which is the worst idea. Post-disaster, you don't ask people to process the trauma, you ask people, what do you need, right? I need a phone, I need water, I need to find my loved ones, and you help them meet those needs. So we really saw that as a gap, this idea that yes, at some point you do, right? And we moved into skills for psychological recovery. Then you can, unfortunately, some people are going to need trauma-focused CBT, but you don't start there, right? You don't ask people to reprocess a trauma they're going through. And that's still something that we struggle with. And it kind of comes to this idea that we need a healthy community. And that's the biggest thing we need when we respond to a disaster, is to have a healthier community to begin with. So I'll pass on to the second question. What's the meaning of partnership and collaboration? I know, Matt, you already kind of talked on this a little bit in disaster response behavioral health. And what role can community organizations and schools hold in disaster response behavioral health? So Matt, you want to kick us off? You always have something to say.
I think there's two ways to look at it. A partnership can be, well, we did an MOU. We got some money, we subcontracted. That's our partnership. Collaboration could be, here's what we bring to the table. What do you bring to the table? If that had been our definition of partnership and collaboration, we would have failed. It is entirely about relationships. And that is a benefit, I think, of a rural community, of a semi-rural community. We do know each other. We had previous existing relationships. We had trust. But I'm also going to say, I had never been involved in, directing or running or doing anything with a grant. I didn't know what it was. It said federal government. I was scared. What are they going to need from me? Oh no. Meanwhile, I was displaced from the fire. COVID had just happened. I mean, we as the folks who were in this work were experiencing significant overwhelm and stress as well. And I have to say, the relationship between SAMHSA and ourselves, and I think Robert can speak to this as well, was startlingly beneficial. It wasn't that it was just stress-free. Melinda, Evelina, the folks that we worked with cared about what we were going through, asked about what we were going through, were flexible. That, I really can't explain how critical that was to the success of what we were doing. Partnerships and collaboration also is, like, you think about all of these fire recovery counselors that day in and day out were meeting with kids and staff and running groups and doing all of these amazing things. Their relationship with the school they were embedded in, many of which were in a different school, a different site, were in a community that did not look or feel the same. They developed meaningful, trusting relationships based on their expertise, based on what they were doing. And that enables them to do the work. That enables a family to listen, to hear that, hey, you might need a referral to behavioral health because this issue is a little more significant than we thought. And that family will take that referral because they trust them, because they have collaboration and a relationship. And I believe at this point, I could just speak about Paradise, California, and our charters in Concal. The school is the community. The school is the community. So it's the center of it. And how the school goes, so the community goes. And so we have found that, I think, to effectively engage and to touch families and to touch kids, you begin with the school. What do you think, Robert?
It's really interesting. I've put therapists in schools since 2011. When I started putting therapists in schools, I was told you can't put a therapist in school. Parents won't like it. They won't allow it. I went to the National School-Based Health Alliance national meeting the summer of 2011 and was told by the CEO, you can't do it. But when you talk about rural areas and you talk about children, schools are it, right? Schools are the center of the community. And so that's crucial. Being known, I'm very fortunate. I lived in Coffeyville. I started the health center there. I started the school-based clinic there. I put the first therapist in the schools there. You know, put some skin in the game. And if you're new to a community, when I put a therapist in a school, right, doesn't know the school, or if I put any staff in a school, the first thing I tell them to know is know everyone. When we talk about stigma of seeking services, you can really mitigate the stigma by, I tell a therapist, know every kid in that school. So when you're talking to a kid, you're talking to every kid, right? I had a therapist that was the math hero that had a secret identity and went into classrooms and did, math games with the kids, and then spent the entire time he was in this school swearing that wasn't him. And so every kid in school would spend their time trying to force him to admit he was secretly the math hero. So listen, be flexible, be part of the community, get to know the community. You're not doing to, you're with. And this really cycles down back to SAMHSA. I know this is, I swear to you, they didn't just choose Matt and I because we're going to say nice things about SAMHSA. Everybody's going to say nice things about SAMHSA. But one of the things they did is we met constantly. And I know that sounds like frustrating, but they were useful because these were meetings led by the people doing the work. I know Matt's presentation made half the room cry when he talked about what they were doing. I mean, my entire staff still talks about Matt's presentation, about what they were doing, and about, that identity of all of us doing this in all of our states together in the school-based program. But I also had to meet with the state of Kansas, right, which had its own grant. So I was routinely meeting with them. I was meeting with the state of Kentucky. I was, so when you're doing something like this and you're discovering it, and I can't say enough, how Melinda and her entire team saw this as a partnership that they were discovering with us. And, when you have leadership at SAMHSA who's letting you be flexible because we're all responding to the pandemic, and they got a special appropriation, so they had to create a program from scratch. So we were all discovering it together. That allows you the flexibility at your local level to discover it with them too, because your federal partner is okay with that because that's how they're running the program. So, I can't say enough that how the funding comes down and how the people who fund you act reflects on whether your program is going to be successful. So moving to the next question, we do want to make sure we get through them all. Recurring and co-occurring natural and man-made disasters have become the norm in many communities, I would say in the entire US and the whole world. What would be the ideal response from various levels, individual, community, state, federal, that would result in adequate support for children, youth, and families? And I know Matt and I have hit on this, but talk about our thoughts on the fact that we live in a disaster world.
Yeah, I mean, I think what we are learning, and I think we all do, whether or not you have had, a disaster before COVID, there's this temptation, I think, after a disaster or during one to get back to an old reality. That's a very normal thing. But I think what we as communities, in really community meaning your school, your family, your city, your state, you can't go back to an old reality. You have to anticipate, plan for, and create a new one while you're moving. Because, we look at paradise, it's not going to be the paradise of old, but that is okay, right? The schools in which we work, they're not going to be like they were, and many of them aren't, and that's okay. So I think the other piece that I would like to see from the federal stance, and I think SAMHSA is doing this well, is to ask rural communities about themselves, because oftentimes grants are written in such a way, they are set up in such a way that we look at them in rural areas and just go, I get what you mean intellectually, but I have no idea how we're going to do this. And so I think part of it is incumbent upon the funder to understand the individual dynamics of the areas that they're funding, with special attention paid to rural and semi-rural areas. because of the lack of services, right? That's it. We don't have a variety of individuals to choose from. And we have to focus, if it's a child-based grant, I don't like the separation. I don't like that we couldn't have clinical support for staff that was formal. I think when you're looking at the impact, it is impossible to separate the resilience of a child from the health of the adult that is sitting in a room with them for 6 hours. And to be able, as the project director or as those that are receiving the funds, to be able not to have to think about that and to be able to serve the system as a whole system, regardless of age, would be critical, right? But number one, I think we have to recognize that this isn't necessarily, these things weren't anomalies, they're patterns. And we have to start thinking of them as patterns and preparing for them as though they're patterns, which I think isn't just federal or state, it's all of us.
So my thought, and I got on this sort of lecture this spring when Russia invaded Ukraine, and how I was hearing it talked about to children. And I realized we talked early in the 2000s, Tom Brokaw wrote a book and everybody was talking about the greatest generation. And that's the generation that lived through the Depression and World War II. So how are they the greatest generation? It's the resiliency that we created, but it's also how they thought about their difficulties. And I have a master's in history, and I look at World War I and the major flu, and that created the 1920s, but then led to the 1930s and even Nazism. So, I really saw that we could either be the World War I generation or we could be the greatest generation. And we had to quit. We talk about it in a negative way, what we've been through. And I can tell you, and everybody can tell you, the positive things that they changed about themselves through COVID or a disaster or what happened or how they realized what mattered or they changed their focus. That's what I think is important, is this idea that how we respond to a disaster, how we, especially with our youngest people, they can either think the world is ending or they can think the world is a place they can live through and recover and they can build strength. And so that's where we've been going with a lot of our work. So talking about the final question, what did the grant lead you to do differently in your work and what are your next steps? Where are you going from here? And I know Matt has some exciting work to talk about.
Well, I think this grant and really all of the grants that we've been a part of have enabled us to better understand community level disaster. It's helped us understand the limits of strictly clinical work. It's helped us to understand the importance of having folks who are part of the community come and volunteer and be part of grants, how critical that is. It's helped us understand that oftentimes what staff and the adults in the system need is just space. They need space to understand that it's okay to be incredibly overwhelmed, to learn really basic tools, to be connected to one another. Disaster, oftentimes, especially with COVID, you just couldn't see people that you were used to seeing, which sort of robs us of our self-regulatory tools that we usually use. So I think it has enabled us to understand there isn't really a piece of the system that isn't touched by disaster. And that if you just put safe, effective, well-trained people in front of kids, kids are going to utilize that service. I was shocked about how many kids saw fire recovery counselors virtually when they were out of school. I was shocked about how many kids saw our substance abuse counselor. So it's enabled us to serve and to acclimate the community to behavioral health services and focusing on social emotional content and wellness in a way that we had to do.
So Matt, it's Melinda, I'm going to jump in because there's a question that I'd like both of you to address that's come in from the audience about what is an example of how schools and parents could communicate about the Ukraine crisis with a more resilient mindset. And I'm wondering if you learned anything from this work that may have helped prepare the teachers and your therapists in a way that they might have responded differently to a unique situation, right? Where kids are seeing a lot of things on TV that are very disturbing, and a different kind of disaster. I wonder if you've seen how that makes that connection.
Matt, I know will have something great, but one of the things that I really, just how we talk about things, what I see is this idea of the world is ending, the apocalypse. You know, we want to sort of grovel in how bad everything is. There's some level of comfort there, but it's destructive, and it's especially destructive for our kids. So even in talking about Ukraine and Russia, first of all, it's far away. Secondly, it doesn't directly impact you on a daily basis. And we can talk about, you know, the difficulties. But I would really focus, you know, you can't lie, and you shouldn't lie, and you should be honest. But this sort of joking demeanor that people have about the world ending, that's not joking to kids. And I know Matt I'm not a therapist, I'm not clinically trained, probably has a lot better to say on that. But I just think how we respond, I mean, responding with resiliency, responding with it'll be okay. You know, we've been through a lot before. I think you can even talk about, you know, this is something that happens. But I'm sorry, Matt, please go ahead.
I think you're absolutely right. I mean, I think I think it's impossible to separate and isolate just a conversation about Ukraine, because it's on the heels of ongoing unpredictability. So we have children who are born in and have learned the world is an unpredictable place. To have 2 straight years of crisis is, we don't understand the impact on kids. What I think the most basic thing is to limit exposure, right? I would rather the information about this event come through me, come through an adult who understands the nuances of it and can boil it down.
Turn off the TV.
Turn off the TV. You know, we had to do that. We had to tell each other that after the fire. We were all being exposed, trying to desensitize ourselves to it. It's a very normal thing. It's what the brain does, like make this stop. The problem is it doesn't work effectively, especially if you went through the crisis. And I think the other thing is we assume that a kid might not be aware of it. So we go all the way over to the other side and think, well, it's not a big deal. But it is, because the level of exposure they have to information as a whole, all children, is tremendous. And so to make space for, do you want to discuss this? Validate. Do not assume you know how they feel, and leave space for them to feel any way they want, and continue to check in about it. Don't tell them things are going to be okay. We don't know the answer to that oftentimes. But to work with their fear, to work with their numbness, their apathy, whatever they bring, to validate that. And to recognize, I think that we all do, that this is a tricky time to be alive, and it can feel really scary, but right now you're okay. So we can assure that the moment is safe while validating that this is such a difficult experience for all of us.
I know we just have a couple more minutes, and I want to get to this other question, which is about whether it's an urban entity or the federal government. How do you feel like they haven't understood your context, or why haven't they understood what it's like in a rural area or for a rural area? And Matt and I both, we talked, obviously we prepared for this. And one of the things we talked a lot about was this idea that we think about rural areas for what they lack, right? They don't have providers, they don't have resources, but we also forget what they have. Everybody knows everybody. There's a community. There's, people can come together. I mean, so much of the time when I wanted to do something crazy, some really odd, new thing, we're going to do something different. We're going to try something new. It's because people know each other that can happen. Because the superintendent and the health department director and the hospital CEO and these people, they know each other, they're around each other, and they all live in the same town. So that kind of gets at, when you talk about people that want to fund activities or want to hear, the humility. I have to have humility. If I'm going to work at the local level, I have to listen. And also they need to be willing to accept that their first idea may not work, but as long as you are achieving the goal, if you're getting where you want to go, which is a resilient community or whatever the goal is, it shouldn't matter. You got to let them change and be flexible, especially when we're talking about a disaster.
Yeah, that's a great question. Our Bay Area funders, I think, have been great. I don't, work directly with them. We have North Valley Community Foundation, which often works with larger funders. I just think that there's a uniformity to the way that sometimes federal grants are written. And the uniformity then is interpreted as you don't understand that. Like, this is not like, we can't, come on. And so I think SAMHSA is a great example of how the response to that is actually the important part, right? Like, systems are inhuman. SAMHSA has infused some humanity into this process and said, it's okay. What do you need? How do you need to be flexible? How can we shift? COVID was part of the cause of that, but I think there's a lesson learned in that, which is that should be business, right? That should be the way business is done, not just because we were in a crisis, but because that's what communities who don't have access to robust services, have very few community-based organizations that provide direct service. That's what we need.
Do with, not to. And I'll pass on to Melanie, not that I'm in charge of this, but I know it's time for it to end, and I didn't know if you wanted to finish this up.
I really truly appreciate the conversation that was had and just the amount of amazing work that's being done in these communities. I really appreciate and thank you for allowing me to introduce you. So I'm going to hand it off to Amy. Um, and again, thank you all for participating.
Thank you, Melanie. And thank you again, everyone who participated over these last 2 days. I mean, honestly, wow, humbled and encouraged by the caliber and quality of all that was said over the last 2 days, and really hope that you are leaving with a sense of how your own practice or own life can be adjusted to consider and include people who are often forgotten or unseen in the process. So we are going to close. No need to hang on for too long, but a couple of very quick logistics. Wanted to invite you to our Gather Town Happy Hour. Lindsay, I think we'll post the link again here. This is a chance to interact with some of our team before you end your Friday. The second is you will be receiving an email, hopefully very soon, with a survey requesting feedback. In that survey, we will be asking about how we can improve this event, and keeping in mind that as we look to the next year, our hope would be to have at least some portion of this in person in some way. So we look forward to getting that feedback from you. Really do encourage you to respond. I want to say a very special and heartfelt thank you to our ASL interpreters who have made this event accessible to so many others, and just such an important partner in the process. So sincere thank you. And for our sponsors, CDP and GatherTown, as well as a couple of others. And I just, again, heartfelt gratitude on behalf of the Crisis Emotional Care team and Vibrant Emotional Health. We wish you well. Have a fantastic weekend. Be well.